Hi, this is Dr. Nick Biasotto, your host to the podcast of the Medical Society of Delaware, Delaware Healthcare Reality. Just to let you know, we have three big events coming up for the Medical Society of Delaware. On October 18th, the Superhero for Hope 5K Health Fair and Food Drive will occur at Rockford Park. Keep that in mind. On October 23rd, as part of MSD's annual meeting week, a virtual CME program with this year's theme, The Body Connected Healthcare Wearables, will occur. And don't miss the 236th annual meeting of the Council session on October 25th with keynote speaker Stephen K. Klosko, MD, MBA, author and former president of Thomas Jefferson University, who will present Swifties, Startups, and the Singularity. For details for all of the three events, go to the MSD website at www.medicalsocietyofdelaware.org. That is, again, www.medicalsocietyofdelaware.org.
Welcome to Delaware Healthcare Reality, a podcast presentation of the Medical Society of Delaware with Dr. Nicholas Biasotto. Dr. Biasotto is board certified in family medicine, and he has extensive experience and training in treating patients with addiction and substance abuse. Now, let's join Dr. Nick Biasotto for Delaware Healthcare Reality.
Hi, this is Dr. Nick Biasotto. I'm the host of the Medical Society of Delaware's podcast, Delaware Healthcare Reality. Before I introduce our guest today, and it'll be an interesting conversation, I'm sure, I would like to just remind you that if you enjoy our podcast, or if you haven't enjoyed our previous podcast, we've had about 30 of them that have been released. They're all pretty good, in my opinion, and a lot of opinions that we're getting, they are pretty good. They're both educational, informative, and you should take advantage of them. But here today, after you get done listening to this, you might want to look at the other podcast. Our guest today is Dr. Matt Cadell. Matt is a graduate of the University of New England College of Medicine, where he's received his osteopathic degree. His college years were in CUNY University in New York City. Dr. Cadell has been practicing occupational medicine for almost 25 years in different clinical settings. That is urgent care, community hospitals, academic institutions, and a public health clinic in New York State, and in various roles such as staff physician, assistant professor, and hospital-based medical director. Dr. Cadell is presently working as a staff physician at Bay Health, walk-in and occupational health in Milford, Delaware. Also, Dr. Cadell is an active member in both the Medical Society of Delaware and the Delaware chapter of the American Industrial Hygiene Association. Professionally, Dr. Cadell is most proud of his case report publication in the American Journal of Industrial Medicine in January of 2024 on a worker diagnosed with interstitial lung disease from exposure to corian dust. Outside of work, Dr. Cadell spends much of his time with his family, enjoying them in New Jersey and exploring the uniqueness of all things Delaware. Welcome, Matt, to the discussion on occupational health. Now, I know prior to talking with you last night,
Sure.
I always prepare for my podcast by doing a bit research. But I scratched my head about this particular topic and said, what am I going to research? So give me a little bit of idea about what you do, what is occupational health, and we'll go from there.
Not a problem, Nick. So I use the term occupational medicine. Mm-hmm. Now, for listeners, they can look at the lecture I put on the MSD website, which was for the hot topics on occupational medicine. And it's more formal, more didactic. But there was a slide there I had, which was a Venn diagram. On the lower right is clinical, over here is occupational health, and on top is business to business. To me, these three together is occupational medicine.
I understand. Yeah.
So the clinical part is, I'm also board certified as a family practice physician. It really is primary care medicine. You're seeing working aged adults, primarily for occupational injuries, but for it to be a quality visit, you kind of expand the scope of the encounter. So you check their blood pressure, heart and lungs. You kind of give them a feel that this is a clinical visit. In the occupational health circle, that, what everybody uses, is more OSHA, NIOSH. Okay, so these...
What is NIOSH?
National Institute of Occupational Safety and Health.
Okay, go ahead.
So I'll just give some background there. So OSHA, the Occupational Safety Health Administration, was put into law by the OSHA Act in 1970. It was signed by Richard Nixon. It was a very progressive Congress at the time. It was bipartisan support. One of the features of that was to have an academic research arm, which is called NIOSH. So all of the occupational research in this country comes from NIOSH. NIOSH is internationally renowned for its work. During my professional career, when I was doing my occupational medicine training in West Virginia, I worked at the NIOSH facility in Morgantown. And these facilities not only train occupational medicine physicians, occupational health nurses, industrial hygienists, and safety professionals. There's about 20, 25 of these centers throughout the country. So it's really important. And then on top, you have more of a business-to-business, which is your workers' comp. So when I talk about occupational medicine, I'm using the perspective of that I'm capturing all of this.
Right.
So that, to me, is occupational medicine. It's clinical, again, primary care. The occupational health piece, you're pulling in OSHA, NIOSH, industrial hygiene concepts, and then at the end of the day, it's a conversation you're having with the company.
All right. So give me an example of what you do. Say, I know that you're working out of Bay Health.
Yes.
And you're a urgent care center, supposedly, or
we're both.
Okay.
We're both.
So you see an individual who's been injured at work.
Right.
And they come to you, and let's say it's a laceration on their hand.
Gotcha.
You take care of the problem, you take care of their injury, you sew it up, you do whatever you need to do to make it better. And then where does that patient fall into, where does that patient go from there?
Great question. I would actually go to a step before that. So we'll call this injured worker Bob.
Right.
Bob is at work, he cut his hand. Bob can't make this a workers' comp case until he notifies his employer. His employer carries the workers' comp insurance. Be that Travelers, Nationwide, or whoever. So then Bob tells his employer says, go to this clinic to get treatment. The employer is responsible for providing prompt treatment. The scenario you described is a non-emergent case. Unfortunately, there are workers who get significantly injured at work, and the good employer will acknowledge that, recognize that, and say, go to the emergency room.
Right.
So when they come to me in that type of situation, they already have a workers' comp claim number. That means the employer has called the insurance carrier, say Nationwide, said, hey, Bob Smith, he cut his hand. He's got to get medical treatment. So now the employer is activating his workers' comp policy. That's the only way you can see me. You got to come in with the claim number.
Sure.
So then I see him, I evaluate him, and it really depends on the acuity. If it's a simple little repair, I will then monitor him clinically. So with workers' comp, there's the indemnity disability side, and there's the medical side. So I'm doing the medical side. The indemnity disability side is, I would then say, okay, Bob, I don't want you using your left hand at work for the next 3 or 4 days. So I do restrictions, and that then goes back to the employer. So now the employer has to make a choice. Can I use Bob at work, not using his left hand, or I can't? And then Bob would be better off just going home. So, and that captures more the disability conversation of workers' comp. If the employer accommodates, that's called a temporary partial disability. If the employer doesn't accommodate, that's a temporary total disability.
For the amount of days he needs for that laceration?
Yeah, as defined by me, as the provider.
Okay.
So if I see him back, say, in 5 days, I would just treat it as any other case. But the background music to this is, what's his disability status? Because the goal is always to try to get him back to their pre-injury state. And hopefully this doesn't become anything that requires anything more invasive.
All right. So he just had a laceration. You sewed him up. He's coming back to you in 5 days for a follow-up in that regard. His employer is aware of this and says, I can still use him,
right,
but I'll put him at a desk for, a few
That's
days.
the smart employer.
Okay.
Because what the employer has done, the employer is allowing Bob to stay at work earning his full salary. his full wages. If the employer says, I can't use you, now it's a temporary total disability case.
And what does that mean?
That means after the third day here in Delaware, Bob is now entitled to wage replacement. And as we were talking about last night, Delaware is unique, like 5 or 6 other states in this country, where the entry into the indemnity side of workers' comp is such a low bar. It's only 3 days. And once you get into that, now you get in disability payments. And for some workers, it just becomes now more complicated. Because it's these cases that really set up a potential legal case.
After 3 days.
After 3 days. The whole system's been flipped on.
Now, you mentioned when we spoke earlier, you said that there is a state that has it up to 10 days or so.
Yeah, the majority, like the states I've worked in, New York and New Jersey, they say 7 days. And so I don't understand why Delaware's doing a 3-day mark. The downside of doing it at 3 days is something that transient or minor that happens at work. So let's say Bob was just walking into his office and he kind of stubbed his big toe. Okay, technically he did hurt himself at work, but is he really going to report that? No.
Right.
So that's something transient, something very mild. But for some workers, that's enough. And now by the third day, they can activate the entire system of benefits. New York and New Jersey is 7 days. So by kind of drawing this wait period out a bit, you kind of weed out this type of scenario. Because if a worker really wanted to push this, say, I can't work because I stubbed my toe or whatever, guess what? You got to wait 7 days. And during that period of time, you got to use up your own time, your own PTO or whatever. So it's a little bit more of a challenge to do it, say, in New York and New Jersey, where the wait is 7 days. Delaware is easier. It's only 3 days.
I didn't ask you this, but do you find that there are some people that are malingerers that come in and look for
human nature
for that
is,
disability?
There are. And human nature is what it is.
It is.
And like any type of insurance, there's a concept called moral hazard. If you're insured, you're going to perhaps act a certain way. If you have insurance on your car, you may drive a certain way. So it kind of, it's kind of reinforcing perhaps some negative behavior in certain patients. I can get a feel if that dynamic is present, and I'm very careful to say to them, workers' comp is not this, it's not this golden gift that on the other side of the rainbow or something. I mean, right. It's really a hassle.
And you also get a lot less pay during that period.
You get in 66 2/3 of what your take-home salary is.
So that could be quite substantial over time if the patient continues to take that route.
Without a doubt. As we were talking about last night, in the state of Delaware, every state bases the wage replacement on what's called their average weekly wage. That's defined by each state's Department of Labor. And that's done for unemployment insurance. But the way workers' comp operates, it's not giving you your full wage. It's 66 2/3. So 1,300, 66 2/3 is about 930. So that's the max you're going to get. So let's just say you're a master electrician. That's not, you can make easily much more money than that.
Sure.
So it's one thing I would like to see the state do a little bit better is to actually increase the average weekly wage so the 66 2/3 is now over $1,000 a week. This is not taxable as well, and which is similar to what New York and New Jersey and Pennsylvania are doing. So the states contiguous to us are actually replacing wages, I think, better. And as we were talking last night, the state of Iowa really is an extreme example where the 66 2/3 works out to be $2,000 a week.
Wow.
So what you have when you talk about workers' comp, every state system is different. It's such a fragmented, confusing system, and that's why we have attorneys to help the injured worker figure out not only their own system in their state, but to figure out like the hypothetical where Bob works in Delaware, but he lives in Pennsylvania, and the headquarters for the company is in Illinois.
Wow.
So it's called jurisdiction. And a good workers' comp attorney can kind of eyeball those 3 states. Generally, where the injury occurs is kind of where the case is. But when I was working in upstate New York, I dealt with injured workers from Massachusetts, and I don't know how the attorneys did it, and they were with me in New York State.
So you would recommend that they extend that period to about 7 to 10 days?
Yeah, because it's weeding out this type of behavior, the malingering behavior.
Right.
The bar is too low, and then once a person, because the majority of the states are doing 7 days anyway, and so you go to the 7 days, and now you're doing the average weekly wage at a more respectable value, which, again, if you just look at our contiguous states, it's over 1,000. We don't have to do what Iowa's doing, which is 2,000, but it's.
What are we? Ours is not.
It's about 930.
So it's almost 1,000.
It is, and every July 1st, the Department of Labor increases the average weekly wage by $50. So you take that, and again, this is all done for unemployment insurance. Workers' comp is 66 2/3 of that. Mm-hmm. So $50, 66, maybe that's 30 some odd extra bucks that goes to the workers' comp. Mm-hmm. So when you're doing occupational medicine, you kind of have to keep this workers' comp dynamic in mind. Now, there could be situations where I see an injured worker, it's the closed head injuries with concussions. Mm-hmm. I keep them out of work. It's probably the only type of worker where I'm very cautious.
Of course.
They got to get cognitive rest, physical rest, meaning they can't go to work.
Well, they're going to be beyond that 3 days without a problem.
That's the issue.
And they're going to be only getting 66 2/3 of their pay in that period of time. Now, God forbid it's a real serious injury like a concussion and he had a severe concussion. He'd be out for a long time.
Yes.
So during that period of time, he would be only getting 66 2/3 of his pay.
He would.
Now, that's going to put a strain on the family if they were accustomed to 100% of that, not 66 2/3. So it would give them an impetus to come back to work as soon as they can.
That's a good question, because the other thing that's happening with workers' comp, even though it's not taxed, so you can think of it that way.
Okay, you get a little bit of break there.
Yeah, you are. Mm-hmm. But you're not working you're not contributing to your 401k. You're not, dental benefits. All these benefits you have with your employer, you're not receiving because his salary is coming from the workers' comp system. And like Bob, we were just talking about, what if he had a second job where he was making more money? This job he had with the company where he got injured was just really for the benefits. Now he's losing even more money at the second job or third job.
Can he work at that second job and not, because the employer in the first job says, I can't use Bob with that left hand that's been injured, but in the other job, his second job where he makes more money, he's sitting at a table and they could use him. How does that play in? In other words, the first guy says, no, I can't use you. You go past the 3-day period. You're getting 66 2/3 of the salary you made in Company A, but you work in Company B, and you're allowed to continue working in Company B. How does that play into it all?
That's really up to the employer at Company B.
Okay.
There's no legal responsibility that employer has.
Right.
It really depends on the type of work Bob is doing. If he's just sitting at a desk, he could probably still do it. Mm-hmm. But it's really up to that employer at Company B.
Okay. So your desire is to first extend our period.
Yeah.
And make our compensation a bit more than
respectable. It would represent our contiguous states.
Right.
So that would be the way I would go about doing it. But per our conversation last night, what I see as an issue here that we have in Delaware is that it's a federal OSHA model, which means that, so OSHA, as I was just telling you about, was signed in 1970 by Richard Nixon. This is legal law. Employers have to follow these standards. Correct.
Standards
for asbestos, silica dust, lead, anything you can name it.
Safety at the workplace.
Yes, yes. So these are laws, legal laws. So so the federal government has a version, and half of the states say, federal government, we're just going to, in our state, we're going to do what you're doing in Washington, D.C. About 29 states actually have said to the federal government, we appreciate your model, but we'll build off of that. We have unique labor issues in our state that we want our health and safety standards to address. The big issue is federal OSHA doesn't cover public employees. It only covers private employees. So what do you do for your public workforce in your state? It's not very well defined. So out of the 29 states with state systems, 7 of them actually have systems dedicated to their public employees. So when I practiced in New Jersey, New York, they actually had very dedicated programs for their public employees. For example, New Jersey has an indoor air quality standard. Federal OSHA doesn't have that. So, you're capturing public employees, but the standards are they're so much more modern.
Well, many companies are interstate. I mean, they're all over the place. Yeah. Can the feds come in and make a general blanket condition saying they'll control the whole thing instead of allowing states to do their own thing?
The federal government's like, I think at this point with their current administration, they would actually prefer the states to take on this responsibility.
Okay, understand.
So, but I guess if I'm following your question, if you had a company in Delaware, but you also had a company in California, which is Cal OSHA, which is a lot more stricter than the federal model.
Right.
In California, you have to follow Cal OSHA. In Delaware, since we don't have a state plan, you got to take the federal plan.
Okay, I see. It's confusing, though, isn't it? Well, the guy in California is going to do really well altogether that injured himself. Well, the guy in Delaware isn't going to do so well.
Well, no, I think you're kind of mixing that up.
Okay, go ahead. Straighten me out. Straighten me out.
So the injured worker, okay, in terms of prevention, these OSHA standards are for monitoring of any hazards in the work environment.
We understand that.
That would be, in theory, should be a safer work environment in California.
Correct.
They have ergonomic standards. The federal government tried to pass one in the late 90s, and it was Bush Jr. just didn't sign off on it.
Okay.
And when you look at the Department of Labor, OSHA, each presidential administration has their own feel on it. In recent times, the Obama administration was probably the most progressive with it. Mm-hmm. And actually, the Biden administration did fairly well, too. Mm-hmm. But each political party has their own, each president has their own take. Historically, it's interesting how in the 1970s, it was truly a bipartisan issue. So it went from Nixon to Ford to Carter, and with each year, it just got a more stronger program, more robust. Mm-hmm. So at the end of the day, states are left with the decision: do we take the federal model, or do we try to develop our own? And it's interesting how Maryland has just put out a heat stress standard.
Okay.
You look at landscapers working outside this time of year.
Yeah, 98 degrees.
Yes. And you put in the relative humidity. What's the heat index? Mm-hmm. So the state of Maryland there's only so much time that a certain worker could be working outside based on the heat index. That's the thing the meteorologist will tell you about how it is the temperature feels, because it's taking into consideration the humidity.
Right. Do
they need water breaks? Do they need shade breaks? Mm-hmm. These are things that the state of Maryland has just started as of last fall.
And we don't have that here.
We don't have that.
Okay.
And it was a promise from the Biden administration that was going to roll over. At this point, I don't see it happening. Okay. The current administration is really cutting back on there's a lot of rolling back of OSHA standards at the moment. So I'm in doubt that will ever happen at the federal level.
Okay, so my other question is this, that you're a primary care doctor, so you're treating primary care injuries in your office at Bay Health. So you're taking care of the lumps and bumps and backaches and stuff that may come to you as a workman's comp injury. I am not certified in workman's comp. I decided not to do that.
Right.
But I see these injuries in my office frequently. I see people who say, I hurt myself at work, my back is out. I have to take care of their problem, but how do I address it as efficiently as you do?
Well, first off, are you a certified provider?
A certified provider, workman's comp provider.
Yes.
I am not certified in workman's comp.
Well, technically you shouldn't be doing those cases.
Well, I can't say to my patient who trusts me,
I know.
I hurt my arm at work, Doc. What do you think?
Well, that just means you're opening up the bigger conversation with workers' comp. So if you're not certified, the Delaware Department of Labor Division of Industrial Affairs, the medical unit, they have sections, and one is for provider training, provider certification. So every 2 years you do an online course, which kind of gives you the feel of the Delaware workers' comp system.
But I did that I did that because I did not want the hassle of when it goes to court.
I know. So what you're doing is you're providing good medical treatment, but you're not giving the disability opinion.
Correct. That's no doubt.
Yeah, so you're not really doing the full thing.
Okay.
So maybe if you're seeing more of these cases, you should think about getting certified because...
No, I don't see a whole lot, but I'm just saying that, and I really avoided that certification because if it does come to litigation, I don't like the process. I don't like to go to court and testify, and I don't like the paperwork. So I said, there are people like you out there that can do all this. Now, we have a company, Concentra,
yes,
which does that type of work.
Yes.
And they're certified workman's comp and all of that. And they're a private industry, and they also are stock. They also have
publicly traded.
Publicly traded.
Yes, they are.
Now, how do you feel about that? Let me just talk to you.
I think Concentra is a real interesting case study because remember I was talking about the Venn diagram. The top here is business to business.
Correct.
Concentra, as you said, is a public company. They trade about $20 per share. They went public last July. They give a small dividend of 6 cents. And they just had an earnings report just on August 8th. I follow them because I'm really interested in it. And they do revenue of about $500 million a quarter. So they have over 600 clinics in this country in 47 states. They got 3 in this state, Northern, and they are growing leaps and bounds. They have taken over Pivot. They've taken over...
Pivot was a former... it still is a physical therapy group, correct?
Right, that actually had workers' comp built in.
Great.
So they took over the Pivot practices nationally. They took over Nova Medical. They grew a lot in 2025. If you look at their financials, they're actually a little bit heavy on their liabilities at the moment. So they're kind of carrying a little bit too much debt. If you really get into the nuts and bolts of their pro formas, you will see things like, I calculate the liquidity and the solvency ratio, and they are a bit over leveraged. Public companies can do that because they're expecting heavy cash flow, so they're willing to carry a debt in a short period of time with the anticipation there'll be a cash flow coming in to cover that.
Understand. Now, you're working out of Bay Health, which is a hospital, which in turn gains the financial benefits that you provide for the hospital as seeing workman's comp-related injuries. How come other hospitals aren't doing that?
Yeah, it's tricky stuff. Just going back to what I was just saying about Concentra, I mean, this is a model from a public company that has revenue, that has profits,
and they're making money,
and they have investors.
Right,
we can buy shares of it today. Unfortunately, a lot of hospitals, in my experience, kind of always lump occupational medicine in with the cost center, where there's no revenue responsibility to it. They just see this as a very passive service. And what the interesting thing I find with Concentra, here we have a stark contrast to what a lot of hospitals just see it as a cost center, whereas Concentra is finding revenue, profit, and investors. And so the question is, how is Concentra doing that? What is their secret sauce here? I like to think they're just very good with marketing to companies, but I've heard the other side, the darker side of this, that the docs at Concentra, the providers, are just, it's a patient mill. So I don't know. I really don't know, but I do know they're doing well for themselves. And I think in this day and age where hospitals are struggling to find new revenue, this should be looked at.
Good point.
Information about the Medical Society of Delaware can be found on our website, medicalsocietyofdelaware.org. Questions about our podcast can be emailed to healthcare.reality@medsocdel.org. That's medsocdel.org. Once again, here's Dr. Nick Biasotto.
Hi, this is Dr. Nick Biasotto. We're back from our break. We're speaking with Dr. Matt Cadell regarding occupational medicine. And I would like to talk now a little bit about the NIOSH that you mentioned.
Right, NIOSH. So I would want the primary care docs out there to realize how important NIOSH is in our country. So NIOSH is required per the OSHA Act of 1970. OSHA said at the time that there has to be a research component to our occupational safety and health programs in this country, and that falls under the term of NIOSH. NIOSH is like the CDC for occupational medicine. Mm-hmm. Earlier this year, we got really close to it being 90% defunded and loss of almost 900 staff. And this was like in the spring. This was like in May. Mm-hmm. And thankfully, the Senate, earlier this month, the Appropriations Committee reversed that decision. Okay. So NIOSH is now going to be fully funded through 2026. Okay. The reason why it's important is I can just speak from my own experience. I mean, on the MSD website there's my Corian case. When I was doing my occupational medicine training at West Virginia University, on campus there was a NIOSH facility. There still is. And when I was there in 2002, we were dealing with the case cluster of workers from a popcorn plant in Missouri that they were doing the flavoring on microwave popcorn. They were using a chemical called diacetyl. And these workers were developing a progressive obstructive lung disease called bronchiolitis obliterans. Mm-hmm. Thankfully, there was a pulmonologist in Missouri that noticed these cases and how unusual these were and reached out to NIOSH. So NIOSH then went into Missouri, they investigated, they did sampling, and when I was there, the researchers were putting together an article that was later published in New England Journal of Medicine in 2002. And I was able to be a part of that in the extent that I sat in on meetings and just casual conversations that made the impression on me on how to properly investigate an occupational disease. So it was that mindset that allowed me to address my Corian case many years later. NIOSH, every time you put on an N95, that's been certified by NIOSH, probably in the Pittsburgh office.
That's a respirator mask.
Yes. Mm-hmm. So at the peak of the pandemic, there were shortages of respirators. Mm-hmm. People were putting socks on their faces, and they were just doing crazy things. And the fact of the matter is it has to be a filtering face piece that fits. It has to fit. It's all in the seal. Mm-hmm. And the N95s are all disposable respirators. But at the end of the day, you don't want to get some offshoot. There was the KN95s, I remember. Mm-hmm. Their filtering efficiency was totally subpar compared to an N95. Mm-hmm. So every time you put on, or a firefighter uses an SCBA, all of that respiratory protection equipment has been verified, certified by NIOSH. Okay. So, and there's so many rich resources on the NIOSH website. I have colleagues of mine that are concerned on a day-to-day basis that certain content's being removed from the website. So visit the NIOSH website if you have an interest in occupational medicine. And if you have an interest in occupational health, I am also participating in the Delaware chapter of the Association of Industrial Hygiene, the American Industrial Hygiene Association. We meet quarterly at the DuPont campus. Okay. And we talk about all things industrial hygiene. So if there's a primary care doc out there that's interested in learning more about the occupational health side, this is a great way to do it. Okay. Because it's probably, a lot of primary care docs are in urgent cares, and they are just kind of learning occupational medicine as they go. Okay. And on one hand, I can get that, because an ankle sprain in your primary care practice clinically looks like the same ankle sprain if you saw it for workers' comp. Correct. It's all the background music. You got to know how to frame that. You got to know the context of that. And that only happens with experience and understanding the occupational health dynamic. And then at the end of the day, making sense of the workers' comp system. So, and I think that's the reason why a lot of primary care docs shy away from occupational medicine, is just this other side of it. They don't know how to wrap their brains around it. Mm-hmm. And it's a very tacit knowledge base. I know it, but I can't really tell you what I know. It's like if you watched me in action, I've had other providers say, "Oh, I see how you're doing it like that."
Okay.
And I'm like, I'm not even aware I'm doing it like that.
You've changed.
Yes, I've done
it numerous times.
Yes, in different levels.
I have to give that pulmonologist some kudos for picking up that pattern.
Well, even the case I had in New York State, a rheumatologist picked up this. So my Corian dust worker, he's 40 years old, smoked half a pack a day, and now he has systemic sclerosis. Mm-hmm. Does that make sense? Mm-hmm. So I tell primary care docs, if you're seeing an unusual illness or presentation, in a patient of 40 years old, I call it, does that make sense test? Mm-hmm. So, and thankfully this rheumatologist in upstate New York was like, that doesn't make sense. He then became my patient in this practice, and then I did the investigation.
Well, I recall this one incident back, I forget the year it was in. It was in the maybe early 90s. I had a case of a young woman who came to me, 32 years old, and fulminant heart failure, edema, anasarca edema all over her body. I didn't know why. She just presented with that from being rather healthy otherwise. I knew her before that. So I put her in the hospital right away because she could hardly breathe. Then I left the hospital that day. This must have been God on my shoulder or something. I turned on a radio, and the radio said, there is a problem with tryptophan over the counter. And it's leading to the early demise of many young people who are using it because it leads to heart failure. I had a cardiologist, couldn't figure out why the heart failure was there either. So I walked back I turn around, this is so weird, I turn around, went back to the hospital, and I asked her, because I hadn't gotten that part of her history, do you take tryptophan over the counter? She said, oh yeah, 4 grams. She is part of and then I published that paper with a rheumatologist because she also had a sed rate off the wall and her joints were killing her. So I had a rheumatologist come in, and he said, I don't know what it is either. But when I came back and found that out, we got together and said, this is the problem. And other places were also reporting it in the country with a batch of tryptophan that has had an oil in it that was causing the problem. It wasn't supposed to be there. It's published, and I was getting calls from all over the country about the publish. What happened with this lady? What'd you do? Yada yada yada. And things did fare well for her because she got over it. But it was an interesting case to see what some of this stuff in our daily life can take our lives.
And I would define that as the does it make sense test.
There, it didn't make sense test. I mean, when she was in heart failure, I said, this doesn't make any sense, and all this joint pain and yada yada. But it was an interesting thing. So Dr. Labowitz, who's passed, and myself published a paper on it in the Delaware Medical Journal, actually.
Very nice.
And it got out there. Wow, this has been a really interesting and eye-opening interview today, Matt. Appreciate it. I learned a lot because I didn't know any of this, and that's why I said, what am I going to talk about when I see you? But I see where you're coming from and how important your position is and what hopefully our state does to increase the time from a 3-day period to maybe a longer period. Have you petitioned the legislative bodies to do this?
No, I haven't.
Why not?
That's a good point.
If you could come up with a proposal, if you're looking to do that, we have a good proposal from you. We can go through even the medical society and give you help.
If I had 4 recommendations, one would be consider adopting a state plan because the federal plan is going to be further diluted in the years ahead. Secondly, go into workers' comp. Don't have the wait period of 3 days. Go to 7. Increase the wage replacement to more respectable, to wind up with the average weekly salary of $1,000. And then, I don't know, again, New York State had this surcharge that was in the workers' comp system to fund the type of clinic I had in New York State. We have a system on them. We had 5 or 6 of them, which were key when 9/11 happened.
Okay, I can see that.
Because it gave first responders a place to go. It became we have clinics in New York City at the time, which was Bellevue, NYU, and there were clinics there. We did sampling, did testing. It was such, looking back, it was such a great resource at the time.
Well, this could be very well this could be done. If you would like to give us a little bit of what you'd like to see done, our legislative committee at the Medical Society is very influential with the legislative body in Delaware. And we may be able to push for this for you. And I think that would be a darn good idea. And maybe you can get the ball rolling here in Delaware and bring us up to date with the rest of the states surrounding us that are doing a little bit better. And maybe we can do even better. But I don't think we'll get to is it Iowa? It's 2,000. It's Iowa.
2,000 a week. No, that won't happen.
I'm not so sure they'll go for that.
But, no, I don't think so.
We can try. Who knows? Well, again, this has been a very interesting discussion. Now, I'd like to thank you for being here and thank you for bringing this to our attention. It's a very important topic. Anyone in our audience who would like to ask questions or have any concerns in regard to this particular or any of our podcasts, you can reach us at our email is healthcare.reality@medsocdel.org. That's medsocdel.org. And this is Dr. Nick Biasotto completing our discussion with Dr. Matt Cadell on a very important issue. See you later.
This has been Delaware Healthcare Reality, a podcast presentation of the Medical Society of Delaware. For more information about MSD, visit our website, medicalsocietyofdelaware.org. For questions or suggestions regarding our podcast, email us at healthcare.reality@medsocdel.org. Thanks to audionautics.com for our music. The executive producer of Delaware Healthcare Reality is Mark Thompson. Delaware Healthcare Reality is produced by Tom Mitten. For the Medical Society of Delaware, I'm Lori Ann Rhodes. Watch for our next podcast episode. Until then, be well. The Medical Society of Delaware, MSD, is providing this podcast for informational purposes only. It provides neither medical, legal, nor any other professional advice. The views, thoughts, and opinions expressed by the host or any guests are their own and do not reflect the views or policies of MSD. Unless specifically stated, reference to any specific product, service, or entity does not constitute an endorsement or recommendation by MSD. Reliance on the information provided in this podcast is exclusively at the risk of the listener. MSD expressly disclaims any and all liability or responsibility for any direct, indirect, incidental, or other damages arising out of any individual's use of, reference to, or reliance on this podcast or the information presented in this podcast.